All right. Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled Breast Reconstruction 101. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, and social activities and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter any general questions into the chat function found at the bottom of the Zoom window at any time. Without further ado, I'll introduce our workshop speaker. Dr. Jewell is a board-certified plastic surgeon and one of the founding members and owners of South Bay Plastic Surgeons, the SPA at South Bay Plastic Surgeons, and the Aesthetic Institute Ambulatory Surgery Center. She completed her general surgery and plastic and reconstructive surgery at USC and LA County Plastic and Reconstructive Surgery Residency Training Program. She has earned a reputation for outstanding patient care and results and has been named one of LA's magazine's LA's Best Doctors annually since 2017. Thank you so much, Dr. Jewell, for being here with us today.
Hi, everyone. Thank you very much, Rebecca, for that nice introduction. This is plastic surgery or breast reconstruction 101, where hopefully you will have all of your questions answered about all of the possible options available for women who are undergoing either a lumpectomy or mastectomy and choosing to have reconstruction. So hopefully at the end of this discussion, you'll be able to understand what exactly breast reconstruction means, why it's important, when it can be performed in patients who have been diagnosed with breast cancer, and what the different types of reconstructive options are that are available. So first, let's start with just a brief description about what breast reconstruction is. So after a diagnosis of breast cancer, women most often will be faced with either the question of having a lumpectomy or a mastectomy. The woman shown in the photograph here has had a mastectomy where her breasts have been completely removed. And the goal of reconstruction is to restore the shape and appearance of the breast either after a lumpectomy or a mastectomy. And what you can see in the second photo is that she has had reconstruction and the shape of her breasts have been restored. Why is breast reconstruction important? I think the most obvious answer to that question is that it improves a woman's body image after what can be a devastating diagnosis of breast cancer. The loss of a breast can have a significant impact on a patient's self-esteem. And as a reconstructive surgeon, we want to make sure that we can restore that positive self-esteem and body image. Breast reconstruction has also been shown to enhance a patient's quality of life. There are many studies that show that patients who have breast reconstruction after a cancer diagnosis and after a lumpectomy or mastectomy report higher levels of satisfaction with their appearance and improved quality of life. Increased confidence is also an excellent side effect of breast reconstruction. It can boost our sense of confidence in the clothes we wear, in improving intimacy, which is also another bullet point at the end, and psychological benefits, which breast reconstruction has been shown to also improve reductions in anxiety after breast cancer diagnosis, reduction in depression, and also a reduction in stress. This can be a very stressful time for patients. When can this be performed? So oftentimes breast reconstruction is done at the time of the ablative surgery. So that would be an immediate reconstruction. And basically, what that means is at the time that the oncologic surgeon or the breast surgeon removes the tumor or removes the breast, the plastic surgeon during that same surgical setting can come in and do the reconstructive surgery. The first patient that was pictured was a patient who had something called a delayed reconstruction, which basically means that the reconstruction was done after a period of time, delayed from the time of the mastectomy. This is more common in women who aren't sure if they want to have reconstruction or may need post-operative radiation therapy. And this just gives some time to help make those decisions about whether and what type of reconstruction they will have after their mastectomy. There's also something called immediate delayed reconstruction, which essentially means that instead of waiting months to years for reconstruction, patients sometimes wait a day or a week or two between the lumpectomy and mastectomy and the breast reconstruction. And again, this is typically done in order to ensure that margins are clear after the ablative surgery, and to also help in sometimes in just coordinating care. So the type of reconstruction that we do often takes many, many hours. And sometimes it's best to do this in two settings to enable the patient to either have the lumpectomy or mastectomy and then come back after a short period of recovery to have the longer reconstructive surgery. And then again, late reconstruction is just waiting many years after the ablative surgery to have their final reconstruction. There are two basic types of breast ablative surgeries, which basically means removing the tumor from the breast or removing a breast. One is a lumpectomy, where it kind of sounds exactly what it is. A little piece of the breast is removed, including the tumor. And the other is a mastectomy, in which the entire breast gland is removed. And sometimes that can include some skin and the nipple and areolar complex. After a lumpectomy, we can perform reconstruction, often termed oncoplastic surgery, which involves kind of rearranging the tissue of the breast to restore the architecture of the breast or improve even the architecture of the breast, fat grafting, and then adjusting the size or shape or position of the other breast. And after a mastectomy, we have several ways that we can reconstruct the breast. So one would be using an implant. The other would be using your own tissue from another part of your body. And then we can also combine those two strategies, using your own tissue and an implant to give you the size that you desire. With oncoplastic surgery, this is typically done after a lumpectomy. And the purpose of this is to fill the defect that the lumpectomy leaves behind. So in this little diagram that I created here, the kind of red star shape is the tumor, and the breast or oncologic surgeon wants to remove the tumor as well as a margin of healthy unaffected tissue around it to ensure that margins are clear. But what happens is if this is not filled in and a patient then undergoes radiation treatment afterwards, or even without radiation, just over time, that area can become concave and oftentimes can distort the position of the nipple and areola, so that this breast that had the lumpectomy is often not the same size, shape, or position as the unaffected breast. So with oncoplastic surgery, what we try to do is to get rid of the big gap where the tumor or lumpectomy was removed, so that there's no space for scarring, so that after a time of healing or after radiation, there isn't a big gap there that can distort the position of the nipple or can create an unsightly indentation in the breast. So in order to do this, we can close that gap, basically just moving around the tissue of the breast. Other times we can move adjacent tissue or tissue around the bra line where there might be some extra skin and fat and just kind of dunk it in there to fill in the gap. And oftentimes we'll do a surgery for symmetry on the other side so that the breasts match, because we certainly wouldn't want to change the shape, size, and position of one breast and not do the same thing for the other. That often is done either with a mammoplasty, a reduction mammoplasty on the unaffected breast, or just a breast lift on the unaffected breast. So here's one example. So this patient had a lumpectomy, and oops, lost my screen here. Sorry, guys. Let's go back. Can everyone still see my screen? Okay, great. I can't. Let me see if I can get, let me go back here. Okay, so this patient had right-sided breast cancer. She had a lumpectomy performed on the right breast. And after the margins were confirmed to be clear, then I came in and did a kind of rearrangement of her breast tissue so that it looked like she had a breast lift. And then subsequently, I did a breast lift on the other side so that the breasts matched in size, shape, and position. Again, the purpose of this is to avoid a significant contour deformity after a lumpectomy, to improve patient satisfaction and overall happiness with their appearance and self-confidence, and also to reduce the need for additional surgeries. So sometimes we don't see patients until after they've already had a lumpectomy and radiation. And unfortunately, after radiation, it makes surgery on that breast really, really difficult. So this can also lead to multiple other procedures to try to improve the appearance of the breast. With patients who we don't see prior to radiation, this is the deformity that can often occur. So this patient had a lumpectomy in her left breast and radiation therapy, and she has, kind of I won't say a golf ball, it's a little bit smaller than that, sized indentation in that breast, and her breasts are significantly asymmetric after radiation. And so for these patients, what we can do is fat grafting. So take fat from one part of her body where she has it and doesn't want it. Most of the time it's the tummy. We filter it and then inject it into the area of the contour deformity in order to fix the defect. And then for this particular patient, I did a breast lift on the other side to try to improve her asymmetry. But ideally, we'd want to catch these patients before they've had radiation. And ideally, she could have had a little lift or a reduction type incision on this side to match the other breast. For patients who choose to have a mastectomy, so basically that means that the entire breast is removed. Nowadays, we try to preserve the nipple and areola so that the breast looks as much the same as possible after the mastectomy, and this is the case with this patient. The breast is removed, and then the plastic or reconstructive surgeon comes in and performs the reconstruction. In this case, the patient had a two-stage reconstruction. The first step was placement of a tissue expander or a temporary implant. And then that temporary expander or implant was removed and replaced with a, in quotation mark, permanent implant. And I say in quotation mark because no implants are designed to last forever. And women who do have implant-based reconstruction, we counsel them to make sure they understand that at some point in their future, they may need to have some maintenance on that breast implant, either a removal and replacement or a removal and replacement with something else, probably their own tissue. In the case of this patient, she wanted to be a little bit more full than she started out. And so I placed an implant that was a little bit bigger than her native breast. And then she had a breast augmentation on the other side for symmetry. Occasionally during these tissue expander and implant-based reconstructions, we will also do a little bit of fat grafting to make the breast look a little bit more natural and to get rid of any edges of the implant that may be visible. This is one of the most, if not the most popular breast reconstruction option because this is the shortest recovery. It's the shortest surgery, and the surgery is typically limited only to the chest. So there's no other area of your body that requires surgery. Implant-based reconstruction is really best for patients who have small to medium-sized breasts. Implants come in limited sizes, and so women who have very large or pendulous breasts may not be great candidates for this type of reconstruction. And implant-based reconstruction is not ideal for women who are having radiation because the radiation changes the quality of the tissues and can be a setup for some implant-related complications. And as I mentioned before, an implant will not last forever, and so maintenance is required for most implant-based reconstruction. Autologous tissue reconstruction or autologous breast reconstruction is the gold standard of breast reconstruction. This is really elegant surgery in which we take one body part, typically the abdomen for most women, and use that to make the breast once it has been removed. This surgery is wonderful because the silver lining is patients get a tummy tuck while they're having their breasts reconstructed. It also requires no maintenance because it's her own tissue, so that tissue is going to age and change and respond to gravity over time like the rest of her body. Unfortunately, this is also the longest surgery and the longest recovery. And so that can be off-putting for a lot of patients just because, having a 6-week recovery or, an 8+ hour surgery can be really daunting for some patients. But this is something that my partners do all the time. I don't do this anymore, but my partners do this all the time, have great results and a great success rate. And again, this really is kind of the gold standard for breast reconstruction because she can live with this result for the rest of her life. The downside is for very, very thin women, this is often not an option because they may not have extra tissue to donate in order to make a breast. For those women, there are many other different options for autologous tissue. We can harvest tissue from the upper back and from the bra line, from the mid back and kind of lateral chest, from the upper buttocks, and even sometimes from the lower buttocks, from the inner thighs, from the anterior thighs, and from kind of the lateral thighs. So if anybody has any extra tissue in any of these areas, then they are a candidate for autologous tissue reconstruction or reconstruction without an implant. And then there's combined reconstruction. So this patient had mastectomies and did not have immediate reconstruction. And because her skin had been damaged with radiation, she required autologous tissue or her own tissue because a tissue expander or an implant would not perform or stretch out that damaged skin. And so for her, I used a flap from her back called a latissimus myocutaneous flap. So a little piece of bra line skin and the muscle called the latissimus muscle was used and tunneled through her armpit and then draped over a tissue expander. So now that damaged skin has its new blood supply and new healthy tissue, and kind of undoes some of the damage from radiation and allows that skin to be expanded to make room for an implant. Additionally, this patient had a nipple areolar reconstruction and also a nipple areolar tattoo. But this can be done with any autologous tissue. It can be done with an abdominal flap, or it can be done with any one of those different flavored flaps that you saw in the previous slide.
Are questions allowed or no?
Sure.
Oh, okay.
Rebecca,
oh, sorry.
sorry, go ahead. No, go ahead.
I was just wondering if you, how far after the mastectomy can you have the autonomous, or
The
can they,
autologous reconstruction?
yeah, or can they be
That
at the
can
same?
be, it can be at the same time. It can be either done at the same time, or it can be done, after you've had the mastectomy for a month or years, and been recovered from that. It can be done at any time.
Okay, great. Thank you so much.
So how does somebody decide what option is best for them? The best thing to do is, once you've had a diagnosis of breast cancer, there's going to be a lot of information kind of thrown at you. Find your team. This shouldn't be something that you sit on for a long time, but don't feel like you have to rush into any decision right away. Take your time to think about all your options. What option first is going to be the best in terms of your long-term survival and outcome? So we want you to have a great cancer operation so that the tumor is removed and it gives you the best chance of a long life with no recurrence. And then after that, think of yourself cancer-free and how you want your body to look cancer-free. So in patients who have a breast cancer diagnosis, meet with your breast surgeon, meet with your oncologist, and meet with your plastic surgeon. So even if you have a small tumor, even if you're considering breast conservation therapy or a lumpectomy, those two terms are used hand in hand, talk to a plastic surgeon, because even with a small tumor, I showed you the patient in a few slides previous that had that kind of golf ball indentation in her breast. Sometimes it's worth talking to a plastic surgeon to avoid that before you have radiation. If you have big breasts, then oftentimes your breast or oncologic surgeon will say that you're a candidate for a lumpectomy. That's great. Lumpectomy, breast conservation treatment, excellent options. Talk to a plastic surgeon, because we want to make sure that we fill in the gap left behind by the lumpectomy, and hopefully make a better shaped breast, a better positioned breast, and then do something to the other side so that they match. And that would be oncoplastic surgery. If you have small or medium breasts, then oftentimes, and a small tumor, oftentimes a lumpectomy or a mastectomy would be good options for you. And with that, again, I think getting input from a reconstructive surgeon is helpful, because we can guide you in terms of how much breast will be left behind in order to create a breast, to reshape the breast. Because if the lumpectomy is a sizable amount of your breast, oftentimes there may not be enough left over to try to reshape into the breast that you want or that you expect. And so a mastectomy might be a better option, just from an aesthetic standpoint. And in patients who have smaller, medium-sized breasts who are candidates for a lumpectomy, more often than not, if you choose to have a mastectomy, we can keep your nipple and areola. And so that will give you a superior result. If you're having radiation, then tissue-based reconstruction is going to be your best option. It doesn't mean you can't have implant-based reconstruction. It just means that if you have extra tissue, that might be a better option for you because it can help heal some of the negative changes that radiation can cause to your tissues. And we know over time, implants just don't perform as well in radiated tissue. If you have a large tumor with medium or small breasts, then a mastectomy is probably going to be your best option. For all the reasons that I mentioned before, there might just not be enough left behind in order to reshape the breast into a breast that is big enough to suit your expectations. If you have a large tumor and a big breast, then sometimes a lumpectomy would be great. I have a lot of patients who have had really large breasts all their lives, and they unfortunately get a breast cancer diagnosis, and they're like, "Oh, I can finally get the breast reduction that I've always wanted." So there can be a little bit of a silver lining with that. So I would, encourage anybody who has really big breasts that is a candidate for a lumpectomy to have oncoplastic surgery so they can get that lifted, smaller breast. And prior to radiation, that's really the key. So basically, your reconstructive surgeon is going to be as important part of the team as your breast or oncologic surgeon, even if you are a candidate for a lumpectomy or decide to have a lumpectomy. So we hope to be part of your team to help you make these decisions. Does anybody have any questions?
Yes, thank you so much, Dr. Jewell, for that presentation. We do have quite a few, so I'm just going to go one at a time.
Sure.
What guides the decision to do direct to implant versus using a tissue expander first?
That is an excellent, excellent question. First would be how big or small the breast happens to be. So, for example, if somebody has a really, really small breast and wants to have a larger breast, then putting in a large implant right after a mastectomy is going to be very, very burdensome to the tissue that's left behind because the skin is kind of traumatized from the mastectomy. And so then if we put a really big implant in there, we're stressing the skin even more. And so that is probably not a great idea. There is a risk that the skin just won't tolerate that much stretch. And that, the skin actually could die under those circumstances. And so for women who are starting with a small breast and want a larger breast, that's really what a tissue expander was made for because it does exactly what its name is. It allows us to kind of gradually stretch out the skin. In a woman who, wanted her breast to look pretty much like it did before, didn't want a big change in size or in shape or position, then I think direct to implant would be a great option. I always kind of use the caveat with my patients that I want to make sure that the skin is healthy after the mastectomy. And there's a way that we can assess that during surgery. We use something called the SPY imaging system. And we basically inject a special dye into the patient's veins. And then we look at the skin kind of under a black light. And the dye will show us which areas of the skin still have a good blood supply after the mastectomy. And if all the skin lights up and the nipple lights up, then we know that that tissue has really good blood flow. And so under those circumstances, a direct to implant would probably be a great option. Unfortunately, sometimes the skin doesn't look super robust after a mastectomy. There could be areas that don't look like they have great blood flow. The nipple can sometimes look like it doesn't have a great blood flow. And so stressing that skin even more by putting in an implant may not be the best choice. It could set the patient up for further problems afterwards. So in that circumstance, a tissue expander is nice because we can put that in totally deflated and or put in a little bit of air rather than saline or salt water. And so that gives the skin an opportunity to recover and to heal before we start expanding and kind of putting more stress on that skin. So I don't often do direct to implant reconstruction because sometimes after looking at the skin during surgery, right after the mastectomy, using the SPY system, the skin doesn't really look like it will tolerate just an implant. And so to be on the safe side, most of the time, I choose tissue expanders as a first step.
Wonderful, thank you. In the case of autologous breast and combined reconstruction, what percentage of the time is the fat tissue reabsorbed by the body? Parentheses, I've heard this can happen, question mark.
Mm. So in autologous reconstruction, where we're actually using the patient's own tissue, um, we bring it with its own blood supply. So basically, this is not a graft. Okay, so a graft is something that, like, I'll use a skin graft as an example. You take a piece of skin, you remove it from one area, and then you put it on an area of the body that doesn't have skin. Well, once you've removed that skin, it is dead. And unless it gets a blood supply in the new area, it will continue to be dead. With autologous tissue reconstruction, we're not relying on it getting a blood supply in the new position. It actually comes with its blood supply. So we take a lot of time to dissect out blood vessels that keep all of this tissue alive. And then we take those blood vessels and connect them to blood vessels in the chest. So this tissue is only without a blood supply for a few minutes until we reconnect it to the blood vessels in the chest. So getting reabsorption after a flap where we're taking a blood supply with it is extremely rare. In fact, the only time I can think that that would happen would be if there's a little area very, very far away from the blood vessels that we want to keep it alive that just doesn't make it. And then in that case, at a second surgery, we might have to remove that tissue. But for a flap, getting a reabsorption of the tissue or reabsorption of the fat does not often ever happen. When that can happen is when we're doing fat grafting. And so, as I was saying before, a graft, we've removed that tissue from its blood supply, and unless we put it in an area where it can get a blood supply within a few hours or days, it's gone. So when we inject fat, sometimes we inject a little bit more than we think we need because we do expect some of that graft to reabsorb. But that really only happens when you're taking tissue with no blood supply and you're putting it in an area hoping that it will get a blood supply as a graft. Did that answer? I hope that answered your question, whoever that was.
I hope so. Thank you so much. All right, this is a little bit longer one.
Okay.
Health inequity makes it impossible to see specialists to perform autologous reconstruction, such as deep flap reconstruction, DIEP flap reconstruction. I was able to see a specialist for stomach flap. However, I did not have enough fat. The doctor was a man. I told him I was okay with A cup. I wanted to see a woman, but that would take long for surgery to remove cancer. Also, to see specialists for gluteal area would delay my cancer removal and constant guiding insurance. It takes lots of time to get insurance to approve out of network. It seems as cancer, it seems as cancer patients have option, but this is not true, question mark. Um, can I get autologous after implant?
Yes. So let me answer that part of the question first, and then we can commiserate about how difficult it can be dealing with insurance companies. Yes, if you've had an implant-based reconstruction and you are unhappy with it, um, you can have the implant removed and replaced with your own tissue. And if you are very thin, or in some circumstances, women who have been diagnosed with breast cancer have already had a tummy tuck. And so, if you've already had a tummy tuck, then your abdominal tissue is no longer available to use as a flap. So, then one of these other flaps would be an option. Um, the reason why this abdominal flap is often our first choice is because it has for most of us, I mean, if you're really, really thin, that's wonderful. But for most of us, we have a little extra stuff here. And so that's why we always try to use this if we can, because this tissue can allow us to make pretty large breasts. I mean, this patient's reconstruction resulted in a double D cup breast. The other flaps tend to be a little bit thinner. They may not have as much volume, and so we cannot, most of the time, make a breast as large as we can make with abdominal tissue. So if you are a thin patient and you're okay with having an A cup breast, one of these other flaps could be an excellent option for you. So it was a little bit difficult for me to understand exactly what the issues were. It sounded like there was maybe some insurance issues. So in our practice, most of the time we're using the abdominal tissue. My partners have, and I have, used other flaps, but we just don't use them as commonly. Um, in terms of insurance coverage, it is very, very difficult sometimes to get insurance companies to cover not only a deep flap, but some of these other, the less common flaps, because they don't have the appropriate codes for them. And these types of flaps are very challenging. They take a lot of time. They take a lot of expertise and training in order to be able to perform them. And so, unfortunately, outside of some academic institutions, you're right, these may not be available options for some patients depending on their insurance. However, by law, you are entitled to have breast reconstruction. And no one can force you to have an implant if you do not want to have an implant. It may just take a little bit more work to find a plastic surgeon that is within your network, within your insurance network, who is available to perform these types of flaps. And in terms of timing, you're right. That's really challenging when you're trying to have a cancer surgery and you want to have the tumor removed as quickly as possible. And so sometimes what we do is we use a temporary implant or a tissue expander as a bridge to get the cancer out, get some, kind of spacer there in order to preserve the skin envelope. Because if we just remove the breast, then the skin would start to shrink. And even if we wanted to use your own tissue, we may not be able to kind of unfurl or stretch out that skin enough. So sometimes we will use a temporary implant as a bridge for patients who may need a more challenging or less common flap, or who were having difficulties in terms of insurance. Now, the downside for that is that's an additional surgery that you may otherwise have not needed. The upside is that it does buy some time in order to deal with some of these kind of nuisances of insurances, so that we can get you the right operation.
Thank you, Dr. Jewell. Do you mind zooming out of your presentation? I think it was zoomed
Sure.
in a little bit to show the different
Oh,
slides.
let's see. I don't see that it zoomed in.
All right, so next question. Um, let's see. Oh, how long is the surgery to place the expanders?
Oh, to place the expanders, that typically is about an hour to an hour and a half per breast. So, if you're only having one side, then, um, if you're having the mastectomy and the tissue expander placed just on one side, then that would probably be about a 3-hour surgery. If it's both sides, then it can be around a 6-hour surgery.
All right, next question. What about revision of surgical scars?
Um, you know, Not super, fortunately, in my practice, it's not super duper common, but it's more common in patients who are having autologous tissue reconstruction, because those surgeries oftentimes are very, very, very long. And sometimes we don't um, get the closures that we really maybe would have done if we were doing like a tummy tuck or something like that. And they're also closed on a lot of tension. So, we kind of remove a lot of tissue at the lower part of the tummy and then pull the upper tummy down. So sometimes that incision can widen over time. And so I would say the most common scar revisions would be on the autologous reconstruction or, like the tummy tuck scar part. Um, in expander reconstruction nowadays, especially since we tend to save the nipple and areola and we hide our scars in the fold of the breast, those aren't as common. But with autologous tissue reconstruction, I think a scar revision should be expected.
Thank you. How often are fills for expanders?
Hmm. Um, I can only speak for my practice, and I think my partners are pretty similar. Other practices I would not be wouldn't be able to comment on, but usually I will fill my patient's expander up with air initially in order to make sure that the skin is not under stress when it's trying to recover from the mastectomy. And I usually fill it up, halfway to 2/3 of what I want the final volume to be. And then usually their first week post-op visit, or sometimes the second week, depending on how the skin looks, we'll remove all of that air and then replace it with salt water. And depending on how big the breast is or how big the tissue expander is, that, to get to the final volume can take, 2 or 3 weeks to get to the final volume. So I would say after surgery, expect maybe 3 to 4 fills done about a week apart.
Thank you. Next question. I am not getting reconstruction, but I'm interested in fat grafting on one side. The other side looks great and would like them to match. Is that typically performed before or after radiation?
Hmm. That's a good question. I would say that that is not something that I commonly do in my practice, but there are pros and cons to doing before and after. The con to doing it before is that it can delay radiation treatment because it's an additional surgery. And typically, we want to start radiation around 4 weeks after the mastectomy or after the lumpectomy. So, doing fat grafting before that time, and allowing time to heal and allowing time for the graft to kind of take will delay the onset of radiation. So that's probably not the best time to do it. Fat grafting after radiation from a treatment standpoint is probably the best option. But the challenge is that radiation really tightens the skin. It makes the skin almost leather-like sometimes. And so trying to inject fat under very, very stiff skin can be a challenge. And I would expect, as a patient, I would tell you to expect maybe 2 or 3 sessions of fat grafting in order to achieve the result that you want. Because we would expect with every session that skin is going to relax a little bit, the skin is going to improve in its quality, but we can't just inject a big, kind of ball of fat, because not all the fat's going to live. It has to get a blood supply. And unfortunately, with radiation, one of the side effects with radiation is that it causes scarring of all the blood vessels in the skin and the tissue. So the blood supply is really hampered in that tissue. So radiation is always a challenge for the reconstructive surgeon. And fat grafting in particular, we want you to have a good blood supply for that. So it would probably have to be after radiation, and then just expect multiple treatments.
Thank you. If you're supposed to have radiation after the lumpectomy, should you wait for the oncoplastic surgery after the radiation?
No. No, definitely have it before radiation, and really just for the reasons that I just said. So ideally, the sequence of events would be your breast or oncologic surgeon would perform the lumpectomy. Let me go back a step. In my practice, we plan this well enough ahead of time. So once the patient gets her diagnosis, she's seen her oncologic or her breast surgeon, they plan to do a lumpectomy. They've seen me, and I've coordinated timing with the breast or oncologic surgeon. So we know we're going to be doing our surgeries within about a week apart. So the patient will come and see me usually the day before her lumpectomy. I will mark on the breasts, planning the incisions. The oncologic or breast surgeon will use those planned incisions to do the lumpectomy. We wait about a week or so to make sure that the margins are clear, because we wouldn't want to rearrange tissue or put in new tissue if we weren't certain that the margins were clear. And then about a week later, I would do the rearrangement or the oncoplastic surgery, do a reduction or a lift on the other side, and then 4 weeks of healing, and then they start radiation. But once you've had radiation, all bets are off. I would not offer a reduction or even a breast lift in most patients who've had radiation, because the radiation changes the blood supply so much to those tissues that problems with wounds not healing, problems with additional shrinkage or changes in the tissue, problems with hardening of the tissue can be really severe.
Thank you. Do you accept Blue Shield insurance?
We're out of network with Blue Shield insurance.
Got it. Do you ever do the lumpectomy tissue remodeling and revision on the other side so they look the same from day one? Can the same surgeon do both? I have larger and wanted smaller my whole life, but mine said that they can only remove cancer. Sorry, it's a little bit.
Yeah, so I think that's probably the breast or oncologic surgeon, but you can and should see a plastic and reconstructive surgeon, because can we do it at the same time? Under certain circumstances, yes, but it's not ideal, because again, we want to make sure that the margins are clear before we start rearranging tissue. So typically, the lumpectomy will happen first, and then the pathologist usually takes about 2 or 3 days to confirm that the margins are clear. And then once we know the margins are clear, we can do the oncoplastic surgery and rearrange things. There are certain circumstances in which we can get reliable margins during surgery, but that is typically in women who have invasive tumors. So if you have invasive ductal carcinoma, then sometimes we can get what are called frozen sections, which means that the pathologist can sample the tissue around the outer edge of the tumor and tell us with some certainty that the margins are clear, but they're not 100%. And so again, just to be on the safe side, in our community, we do like to do this in 2 steps so that we know for sure you have clear margins before we start rearranging things.
So it is a possibility, but it's
It
circumstantial.
is a possibility, but it's definitely on a case by case basis.
Got it. Okay. Next question. How do you know if a person has enough tissue in the abdomen?
So the kind of the easiest trick is I tell my patients to grab their breast and see how much, of a handful or more they have in their breast, and then grab one side of their tummy and see if they can grab as much on their tummy. And if they can, then they're probably a good candidate. If they can't, then we may need to discuss other options.
All right. I had a diagnosis 2 months ago. Can we still do expander and implant? Oh, I had DMX.
Um, Sorry, what was the?
I had a DMX. Is that diagnosis or is that something that means something else? Let's go with
Double
diagnosis.
I
mastectomy.
Okay.
Oh, can you repeat that, please?
I didn't write it, but thinking it's double mastectomy.
That makes
Okay.
sense. Thank you.
So yes, if you've already had a mastectomy and you ideally haven't yet had radiation, then you can certainly still have reconstruction. Once you've had radiation, then using a tissue expander can be very, very challenging. And the risks tend to be significantly higher with tissue expanders in radiated tissue. So we in general like to start that process before you have radiation.
All
Can I
right.
ask a question live?
We have a
Because
couple more
that,
questions.
okay, that was my question.
Okay, go ahead.
So I don't have to have radiation. I don't have to have chemotherapy. I had my double mastectomy 2 months ago. You mentioned that the skin might not stretch as much as if I wait a few months. Is that true? Should I be
No,
worried?
if you have not had radiation, then we should be able to stretch your skin just fine.
Even without expanders. I don't have expanders in now.
Oh, well,
Yeah, I
we
have
would
not.
put in expanders. We'd probably
Okay,
start with expanders and then stretch everything out before we would put in an implant.
okay, thank you.
Mhm.
All right. Um, how long after mastectomy will it take to have a dip flap? I now have an expander and it's being filled every week.
So again, it depends. So I'm assuming that the tissue expander was placed because the patient will likely have radiation. Because one of the things we like to avoid, if we're going to use your own tissue, which is precious, we don't want to put it up there and then get it radiated. So a tissue expander can often be a bridge to using your own tissue because we don't care if you radiate the tissue expander, we're going to take it out. And then we can put in healthy tissue after the radiation. Um, so in my patients, if you have a tissue expander, we are anticipating radiation, and for whatever reason, the tumor was smaller than we expected and you no longer need radiation, I like to wait a minimum of 3 months of total healing before we then do the next surgical step. In the circumstance that the patient is having radiation, then I want to wait at least 3 months, but preferably longer with, to allow those radiation changes to kind of peak before we then go back and do the autologous tissue reconstruction.
Thank you. Next question. I am 3 hours away from you, already had double mastectomy. Can can you do my fills in my area?
So you've had your mastectomy. I'll try to answer this question without all the information, but in one circumstance, I'm imagining you've had the mastectomies, but you haven't yet had reconstruction. So I'm not a huge fan of surgical tourism because I like my patients close to me in case something happens because I want to be able to take care of them. But I have had patients who come from out of town. Um, and for those patients, I would like for them to stay nearby at least a week post-operatively and then be able to come and see me weekly. If you already have tissue expanders, then really who should be doing your inflation is your surgeon, who put in the tissue expanders. Occasionally there are some circumstances where, either that relationship is kind of fallen apart, or, they've changed, or insurances have changed. But usually the person who does the expansion is the person who placed the expanders.
All right, thank you. We have a couple more minutes. And my plastic surgeon stated that there are no saline implants and only silicone. Is this true in California?
No.
Okay.
No.
All right.
So there are both silicone and saline implants. In general, I prefer to use silicone implants in patients who are having reconstruction for a couple of reasons. One is silicone implants hold their shape better and tend to look more natural. And this is really specific to women who have had mastectomies, because there's not as much camouflage over those implants. And so what you can see, and I have used saline implants. I've had patients who, do not want to have silicone implants. That's totally their choice. But I prepare them for the fact that they may see rippling with the saline implants, just because they don't have as much camouflage as somebody who is having a saline implant for a cosmetic breast augmentation and has breast tissue to camouflage it. But yes, they're in the whole United States, there are both saline and silicone implants available.
But she
Wonderful.
said, this is my question, but she says she's going to it's going to be under the muscles. She's going to cut the muscle. She's going to place the expanders under the muscle. So that's why I was thinking, it still have rippling?
It can, because the chest muscle is very thin. And especially after expansion, sometimes it becomes even thinner. So, when we think of like our chest muscles, I think a lot of us imagine they're as big as like some of these bodybuilders who have these really big pecs. Women's chest muscles tend to not be that big, and they're very, very thin. It's a thin, flat muscle that sits here. And it, especially after expansion, does not provide as much camouflage as you would hope to cover up the rippling that can be seen, especially with saline implants, but it can also be seen with some silicone implants, depending on the type of silicone gel that's on the inside. How we mitigate that in patients who either don't want the implant under the muscle, and that's okay too, or who still have very, very thin tissue, is we use fat grafting. So when we swap out the tissue expander, we take out the tissue expander, put in the implant. Sometimes we will put in some fat to try to add a little bit more camouflage to the implant.
All right, Dr. Jewell, really quickly, how is nipple reconstruction done?
I call it skin origami, because essentially what we do, or at least in my practice, what I do, and it can be done several ways, but in my practice, what I do is use a little local tissue flap just on the breast skin. So with the breast skin that is left behind, either after a mastectomy, after the mastectomy, and we can do it with implant reconstruction, we can do it with autologous tissue reconstruction. And we just raise a little bit of skin and then make a tube out of the skin with a little cap on it, and you have a nipple.
Beautiful. What guides the decision to place implants pre-pectoral versus subpectoral?
A lot of it is conversation with the patient. So, my preference, and the data tells us that the safest place for implants are under the muscle. It provides a little bit more blood flow, vascular coverage, so the risk of infection is slightly lower. Camouflaging the implant is better. But the downsides to going under the muscle is that it's a little bit more of a painful recovery, because we have to lift up the muscle. So there's a lot of muscle soreness. And sometimes patients can get something that's called an animation deformity. So if the implant sits under the muscles are fan-like muscles. And then if you flex your muscle, the implant can move up and out. And that can look really weird. It only happens with strong contraction of the muscle, but it can really bother some patients. So in patients who are very active or who, are bodybuilders or, work out a lot and like to observe themselves working out, that might not be the best choice for them. And if you are having radiation with the intention of having autologous tissue reconstruction after the fact, I typically will put the tissue expander above the muscle because we don't need it. We don't need to put it under the muscle. We're going to take that tissue expander out and we're going to fill that space with your own tissue. And then if we're going to take a chance and use an implant after radiation, a radiated muscle tends to scar more. And so you get more of what's called capsular contracture, hardening, kind of in deformity of the tissue expander after radiation. And so in patients who, we've had the conversation and they just really don't want a surgery someplace else in their body, or they're not a good candidate for whatever reason, they know they're going to have radiation, then I would have that conversation with them and say, okay, if we're going to do a tissue expander and implant, we might want to go over the muscle because it's going to probably have the lowest contracture or deformity after radiation. It's not ideal, but again, this is why this is not one size fits all. You really have to have a conversation with your reconstructive surgeon and talk about all of your concerns and all of your and what your treatment is likely to be after the mastectomy or after the lumpectomy. So over the muscle, under the muscle, in my practice, there are certain situations for each patient in which I think either one of them will do well. I think that it is more of a trend to go above the muscle nowadays because, for one, it's faster. And so I think a lot of plastic surgeons like doing it because it doesn't take as long. It is nice for the patients because it is not as much of a recovery, but in terms of aesthetics, unless your breast surgeon and oncologic surgeon leaves a very thick flap, meaning they leave a lot of tissue behind, you're more likely to see the implant and implant wrinkling if you're going over the muscle.
Thank you, and I appreciate your time. Last question, I think this was really important. What might be some red flags to look out for in a breast reconstruction consult?
Ooh. That's a good question. I think if you feel like your questions aren't being addressed, and if you feel like your plastic surgeon is kind of navigating where they want you to go, that would be a red flag. You're not always going to get the news you want. So I think that's a challenge. I've had to give bad news to patients and say, listen, I really wish I could give you this type of result and this type of surgery that you want. You're going through a horrible time right now, but in my hands, I just don't think that I can realistically provide that for you. But I'll be really honest with them and tell them that ahead of time. I think if somebody says, oh, you're having radiation, you've got really large pendulous breasts, but we're going to put in a tissue expander, that might not be the best option for you, And on the other hand, if you have really small breasts and, otherwise are a candidate for an implant and they're trying to talk you into a big, long, autologous reconstruction surgery, that may not be the best option for you. So I think you kind of have to be able to hear all of your options, the pros and cons to all of those options for you, because again, this isn't one size fits all. And whether or not that surgeon feels comfortable providing all of those options for you. As I said, I don't do microsurgery anymore, so I don't offer the autologous reconstructive surgery anymore. My patients will learn that when they call for the consultation. I don't waste their time or try not to, because I know that ahead of time. However, if we're in a situation where they start out wanting an implant, and then there's some unexpected turn where they end up needing radiation, or something kind of gets thrown in the mix there. I have wonderful partners who can provide those services for them. So I think if you don't feel comfortable, then listen to your gut.
Absolutely. And thank you so much, Dr. Jewell, for taking the time and just the care to really explain in such detail that everyone understands. And this is such a wealth of information. So I do appreciate your time and expertise and sharing that with us tonight.